Good morning, guys. How are you? All right, let me know if you can hear me. All right, good. Perfect. Okay, thank you, guys. All right, guys, let's get started. All right, guys, you should have received your NERPs via email. All right. Okay. So we're gonna finish up safety and infection control. We only have how many points today? Not 200. We have 168 points. 178. All right, so let's knock it out. All right, just let me know if you guys have any questions. You can text me or you can email me a little later if you have any questions, okay? Okay, so one thing I want to let you guys know for the Florida Board of Nursing, I have received information that they are making some students do a verbal or oral exam. So if you're having any issues enrolling or submitting your documentations to take the NCLEX, you should call the Florida Board of Nursing. If you're having any issues with scheduling the NCLEX, call the Florida Board of Nursing. There's an issue with the students, the graduate nurses who have the fake license. So since that happened, they're being more strict. They're stricter on who is allowed to take the NCLEX. So if you are having an issue, make sure that you call the Florida Board of Nursing. Don't just give up. All right. Contact them. Ask the Florida Board of Nursing, what is your next step to taking the NCLEX or scheduling the NCLEX? All right. Okay, so let's go. All right, so home safety. Home safety per NCSBN. Assess need for client home modifications, lighting, handrails, kitchen safety. Apply knowledge of client pathophysiology to home safety intervention. So B is apply knowledge of client pathophysiology. So that's for your patients who have CHF, diabetes. Maybe your patient has a CVAD, peripheral vascular disease, peripheral artery disease. So you have to know the client's pathophysiology in order to initiate home modifications and home safety interventions. If your patient has a fresh amputation, a new amputation, that patient needs to have a ramp at home. And also maybe something to assist with bathing and toileting. So I want you guys to, I'm gonna mark it up. I'm gonna put a mark here for client pathophysiology. So that's your clients who maybe they're in a wheelchair, amputation, diabetes, PVD, PAD. Okay. Educate client on safety issues. So I'm gonna circle issues. You have to educate your client on safety issues because sometimes they may not know that that those frayed wires or those extension cords are safety hazards. They may not know. And encourage client to use protective equipment when using devices that can cause injury, like that's goggles, making sure they use gloves when gardening, especially if they have diabetes. So I'm going to underline cause injury. That's especially for your clients if they have diabetes, because you know if they get a little nick from gardening, it can become a big thing. Evaluate client care environment for fire and environmental hazards. So we have to know about fire safety. We have to educate the clients about fire safety, right? All right. So let me pull my notes up. Hold on. Hold on a second. Let me get the answer key. I'm here, guys. I'm just pulling up my key. All right, so let's rock. Okay, so here we go. So home safety measures, remove scatter rugs. So that's the first thing, scatter rugs, remove scatter rugs. Install door locks that cannot be easily opened for their, protection. Some people, they prey on the elderly. So you have to keep that in mind. So make sure they install door locks that it cannot be easily opened. Okay. Place alarms on doors. Place alarms on doors. 4, keep a lock on the water heater and the thermostat. So I want you guys to put 4, underline 4. That's a huge deal for safety. Keep water temperature at a safe level. So I put a little note here for you guys. Make sure hot water tanks are maintained at 120 degrees Fahrenheit. Okay, this level is still considered safe for the majority of the population. So keep in mind what level, you have to tell them what level they should keep the water heater. All right, so make note of that. Provide good lighting, especially on stairs Install handrails on stairs and mark step edges with colored tape. Colored tape. Place the mattress on the floor. Now, this one kind of threw me, but listen, it's evidence-based, so I'm just going to go with it. I don't know why you would put a mattress on the floor. I don't know, maybe for if they can't get into the bed, just put an asterisk next to that. Let me look further into that. All right, remove clutter and clear hallways for walking. So this is huge because fall risk. 10, secure electrical cords to baseboards because we don't want the patient to fall. We don't want our clients to fall. Keep cleaning supplies in locked cupboards. Like make sure the cabinets are locked. It's just a cabinet, guys. Okay. Keep them in a locked cabinet. Cleaning supplies, because if you have someone over, if there's a child, you know, sometimes children, they'll drink, especially if they're the developmental stage of 0 to 2, they tend to put everything in their mouths. So make sure that the cabinets are locked. Install handrails in the bathroom, at bedside, and in the tub. So handrails, okay? So this goes along with our client's pathophysiology. Who would need a handrail? That's someone who may, if they had surgery, if they had hip surgery, if they had an amputation, if they dealing with a peripheral vascular disease, peripheral artery disease. So this is, you have to really understand the client's pathophysiology to be able to recommend when this client will need a handrail. So that's huge. Place a shower chair in the tub. Shower chair in the tub. Again, think about the client's pathophysiology. 14 is wear a medical identification bracelet. Medical identification bracelet. If living at home with the caregiver, if they don't live at home with the caregiver, they should have a medical identification bracelet. Enroll in a safe return home program. Safe return home program. 16, participate in an exercise program to maintain mobility. Like here we have silver sneakers. So participate in an exercise program to maintain mobility. So home safety again. Why are we stressing home safety? Because we are allowed to initiate home modifications in our theoretical NCLEX world. I mean, you can do it at some facilities also. Some facilities are very good about it. So, but for sure, home safety is a big deal for the NCLEX, okay? Especially a first year nurse. You're not gonna get through your first year without recommending someone for something at home. Like when you do your discharge planning, you're going to have to do get in contact with the case manager to do home modifications, all right? To initiate some type of home modifications. All right, so home safety, again, per the NCSBN, this isn't me, this is the NCSBN, right? This is your NCLEX. These are the guys that make the NCLEX. So the NCSBN wants you to know how to assess need for client home modifications. So does the client need lighting? Does the client need handrails? Kitchen safety. So that's your responsibility. Apply knowledge of client pathophysiology to home safety interventions. Again, think about if your patient had hip surgery, if your patient had abdominal surgery, does the patient need the handrails in the bathroom, in the shower? So it depends on the pathophysiology. Educate client on safety issues. That's the scattered rugs. That's the alarms on the doors. Encourage client to use protective equipment when using devices that can cause injuries. So if they are in the garden, if they're working on in the garage, if they're working on cars, they need to be protected. Evaluate client care environment for fire and environmental hazards. Is there a fire hazard? So let's talk about carbon monoxide. Carbon monoxide is a very dangerous gas because it binds with the hemoglobin and ultimately reduces the oxygen supply to the tissues in the body. So carbon monoxide is also a safety issue. Carbon monoxide cannot be seen, smelled, or tasted. Cannot be seen, smelled, or tasted. So that's the issue. It's a silent killer. Seen, smelled, or taste. Manifestations of carbon monoxide poisoning include nausea, vomiting, headache, weakness, and unconsciousness. So these are the manifestations, the clinical manifestations, right? Clinical manifestations. All right. 20, death can occur with prolonged exposure. So death can occur with prolonged exposure. So that's why we have to educate the public on carbon monoxide poisoning. 21, measures to prevent carbon monoxide poisoning include ensuring proper ventilation. Ensuring proper ventilation when using fuel burning devices like lawnmowers, wood burning, gas, fireplaces, charcoal grills. So how do we prevent it? To make sure there's proper ventilation. Gas burning furnaces, water heaters, and appliances should be inspected. Now here we go. Annually. Okay, that's every year. So annually, that's huge. Underline that. Okay, 22 is huge. Take it from me, hint, hint, hint. Annually. Flues and chimneys should be unobstructed. All right, so flues and chimneys, they should be unobstructed. So here's a picture of a flue. This is a flue, so it should be unobstructed. So meaning that should be nothing here to obstruct the flue. Carbon monoxide detectors should be installed and inspected regularly. So that means they should be inspected every 6 months, guys. I think that's what's on the NCSBN, 6 months, every 6 months. So biannually. All right, biannually, you need to change those batteries. That's huge. All right, biannually. And 25, check carbon monoxide batteries at the same time as smoke detector batteries. So when you check the smoke detector batteries, which is every 6 months, you should check the carbon monoxide batteries too. Change the batteries annually on a specific date, like a birthday. Guys, it's biannually, okay? Biannually, twice a year. All right, twice a year. So believe it or not, guys, this is actually on the board. They want you to be able to tell the public when they should change it. It's twice a year. Especially the batteries. Batteries are twice a year. All right, that's huge. So don't forget that. And I know it's petty, but it is what it is. Okay, so home safety. Again, home safety. This is the NCSBN. What does the NCSBN want you to know as a nurse? A first-year nurse. They want you to assess the need for home modifications. So you should be good. They want you to be very proficient in assessing need for home, applying home modifications. They want you to know and understand the client's pathophysiology. So which clients get the additional teaching? Educate the client on safety issues, encourage client to use proper protective equipment when using devices that can cause injury. And again, evaluate the client's home for fire hazards or environmental hazards. So food poisoning, this is another heavy hitter on the NCLEX, guys. So put this in red. Believe it or not, this is a heavy hitter because we all eat and we all store food. Okay, so this is huge for the NCLEX. So food poisoning is a major cause of illness in the United States. So major. All right, food poisoning is a major. So there you go. Put it in red. It's huge. Food poisoning. Most food poisoning is caused by E. coli, Listeria, and Salmonella. So E. coli, Listeria, and Salmonella. 29. Healthy individuals usually recover from the illness in a few days. But think about the word healthy. Healthy individuals. Very young, very old, immunocompromised, and pregnant individuals are at risk for complications. So very young, very old, immunocompromised, and pregnant individuals are at risk for complications. Clients who are especially at risk are instructed to follow a low microbial diet. A low microbial diet. Most food poisonings occur because of unsanitary food practice. So we have to educate the public to perform hand hygiene before, during, and after food preparation, and avoiding the and this is it, cross-contamination of equipment. So this happens a lot. The cross-contamination of equipment and foods, and cleaning food preparation services well. So the raw meat should not be on the same cutting board as vegetables. So they want you to label, recommend getting labeled cutting boards. Like, so there'll be a cutting board for meats, a cutting board for vegetables, a cutting board for poultry, a cutting board for fish, to avoid that cross-contamination. So again, perform hand hygiene before, during, and after food preparation. Avoiding cross-contamination of equipment and foods, and cleaning the food preparation service as well. All right. So the cutting boards is a huge deal. They should be, you shouldn't use poultry and cut your vegetables. So that's cross-contamination. Ensure meat and fish are cooked to the correct temperature. Handling raw and fresh food separately to avoid cross-contamination. And refrigerating perishable items are measures that can prevent food poisoning. So refrigerating perishable items. Check expiration dates and refrigerate perishable items. So make sure they're checking their expiration dates. First in, first out rule. First in, first out rule. Avoid any products made from unpasteurized dairies or meat spreads or uncooked eggs. So we shouldn't eat raw cookie dough We shouldn't eat cake batter. So avoid any products made from unpasteurized dairy or meat spreads or uncooked eggs. Do not eat raw sprouts, damaged or moldy raw foods, or unwashed produce. Make sure you wash your produce. And heat hot dogs and deli or luncheon meat. So heat hot dogs and deli or luncheon meat. Yeah. So these are some points that you have to think of, or you have to educate your clients about food poisoning. All right. Reporting of incidents, reporting of irregular events, reporting of irregular occurrence, reporting of, it's a variance report. It's all an incident report. So remember your synonyms, especially if you're taking your HESI exit exam. HESI is the king of synonyms. So they may say irregular occurrence, or they may say variance report. They may see incident report. It's an incident report. All right, feel assured knowing that, okay, this is just an incident report. The rules apply. The same rules apply. So this is huge because this is a very good select all that apply. This could be a drag and drop. I mean, they can get very creative with the incident report because you are responsible for documenting quite a few things. So this, guys, make sure you do a little note card, like an index card, put it in your pocket and carry it around for like a week. So you can become very familiar and you can become very comfortable with the incident report if they give it to you as a select all that apply. Remember, on the board, you're going to get up to 45 select all that applies. Question. So you really, really have to know your stuff. Detail is very important. So incident report is not a topic that you want to gloss over. So you really want to dig in when it comes to incident report. And I know it's not the cardiovascular system or the neurological system, but it's a point is a point. Okay. So make sure that you really understand an incident report because you can get a select all that apply. All right, so let's do it. So what does the NCSBN want you to know? They want you to identify need situation where reporting of incidents, the event, the irregular occurrence, the variance is appropriate. So they're saying, when do I file an incident report? When is an incident report valid? So acknowledge and document practice errors and near misses. A near miss is just as important as an accident occurring. A near miss can save someone an injury. Evaluate response to error, event, occurrence. Report, intervene, or escalate unsafe practice of healthcare personnel. Substance abuse, you have to report substance abuse. You have to report improper care, and you have to report staffing practice. Okay. So this is huge, guys. This is a big part of it, of the NCLEX. As a first year nurse, you're going to be, you have the most recent up-to-date practices. So you're going to see some things that you shouldn't see, or some things that occur that should not occur. So you don't want to get into a fight, or you don't want to be unprofessional. So you have to know how to handle these situations. You have to report them. So it's a new world, new profession, new way of life, and we report each other, believe it or not, especially if we see something unsafe, if we see someone using substances while working, improper care, even staffing practices, you have to report that stuff. Okay, so this, I want you guys to make sure that you really understand, you know, the profession. Okay, we just don't sit by and let things occur. We have to report it. All right, so 39. Complete an incident report within the specified time frame, and is usually, guys, 24 hours. 24 hours. So that's 1 day. All right. Include the client's identification. All right, here you go. The time, the place, an accurate account of the event, who you notified, what actions you took, and your signature. So you're going to put the time, place, an accurate account of the event, who you notified, what actions you took, and your signature. So you have 1, 2, 3, 4, 5, 6 components of this incident report. And that is the problem with most of us when we answer these questions. Like, I don't know, I'm not gonna memorize all that stuff. Let me go to the cardiac system. No, guys, this is very important. So I want you guys to use your circles, and I want you to put time. I want you to put the place. For 3, I want you to put the account. For 4, who you notified. 5, actions, and then your signature. And number 5 is very important as a nurse. So this, did you call the physician? You should, whenever there's an incident, you want to call the physician. Did you notify the physician? Did you notify the family? You have to notify the family. What actions were taken? Did you get an order for new medications? Did you get an order for a CAT scan? So actions for us is very important. All right, the actions, what actions were taken? What did you do? Okay, did you call? You should have called the physician, and you want to notify the family. You have to let the physician know what's going on, because you have to get more orders, additional orders, and you need to let the family member know, listen, your mom fell. I don't know if you want to come in and take a look at her. This is what we're doing now. That's it. Just acknowledge that it happened, and let someone know. All right, just acknowledge that it happened. All right, call the family, call the physician, and what actions were taken. This is very important. So if you're going to do an incident report, do not put, don't submit an incident report if you didn't call the physician, you didn't call the family members, you didn't get additional orders. Did you reassess the patient? Things like that. So 5, I'm going to erase this. So I'm going to erase it. And for our little boxes, I want you guys to make sure that you fill in your boxes, do it over and over and over. But make sure actions, what did you do? Okay, this is very important, actions. This is us. So, all right, keep that in mind. So 41, do not reference or include the incident report in the client's medical record. So, all right, I have a question. Professor 3 is account. What do you mean? Okay, so account, let me read it again. Include the client's identification, the time and place of the incident, an accurate account of the event. So an accurate account would be walked into the patient's room at 03:13, found the patient in the supine position on the floor, holding his right hip. Just the facts. 0245, walked into the hallway, found patient in the supine position on his buttocks, holding his right knee. Okay. 6 is signature. So I'll go over this again. All right, let's do it again. Let me erase it and do it again. You're welcome. Okay, so 40. Include the client's identification, the time. You want to put the time and place of the incident, an accurate account of the event, who you notified, what actions you took, and your signature. There you go. And you notify what actions you took. And yes, under notified, family physician, right? So an incident report, as a hospice nurse, I did quite a few incident reports. I would go and there would be a fall. So just think about it. If it were your family member who fell and now they maybe have to be transported to the hospital, or they have to do additional tests. So if a patient came in for diabetes management and they fell, and now I have to worry about, I have to take this patient to CAT scan. This patient may have to have surgery for a fracture. You know, that's very upsetting if I go into the hospital if I send my family member for diabetes management, and now like I'm going into the room and there's a cast on the leg and no one called me. Right? So I know most of you guys are thinking now, oh man, I wish someone would, do that to me. It's going to be horrific. Exactly. If you gave a wrong medication. If the plan of care changes, guys, acknowledge that it happened and help the patient. If you gave the patient a wrong medication, this patient is having an adverse event, you need to let somebody know. All right, give me 1 second. Okay, so do you guys understand the incident report? So anything that changes the same doctor and family. Oh yeah, you have to, guys. So if you went into the hospital, let's just say you sent your favorite object into the hospital, because I don't want to bring a family member. I don't want to put that on anyone. So you take your favorite object to the hospital, and this favorite object was supposed to get normal saline, and somehow this favorite object got potassium. So now this patient is having dysrhythmias. This patient is having reaction. You don't want to tell the family? You're not going to tell the family member? Oh yeah, you better tell the family member what happened, so they can come there and see and check on their family. You made them, it's an incident report. You made a mistake. It's done. Okay. So don't continue to just disregard this patient. Now the plan of care has completely changed. So now it's time to let the family know and let the physician know. You're welcome. Okay. All right. So 41. Do not reference or include the incident report in the client's medical record. So there's not going to be any documentation. So let's say, for instance, you use Meditech, or if you use, what did I just learn the other day? It wasn't Cerner. I did another documentation system the other day. Whatever it was, I'm getting old, so it'll come to me. The incident report is a completely different form. So I can do my assessments there. I can do my vital signs. I can do my medication administration. but there is not going to be a tab for the incident report to go into the client's medical record. That is facility policies that comes from the facility. So you have to actually go and find another portal to get the incident report. So if I'm doing my documentation, my daily documentation for my patients, I have to do an incident report, but I'm not going to put the incident report in the patient's documents or in the patient's file. So when I worked for Vitas, if I had to do an incident report, I could not scan and email an incident report. I had to physically take the incident report to my manager. Okay, so do not reference or include the incident report in the client's medical record. So just to kind of alleviate some of your fears, guys, when it comes to incident reports are designed to make the facility better. So if you're working for a facility or an establishment that is blaming you, that is not a good establishment to work for. So you should not feel bad or feel guilty or be afraid to submit an incident report. So you have to work at an environment. If you do an incident report, or if something happens, you want to be taught properly the next time, and you want someone who's on your side, who understands, because I guarantee you that incident report was due to a system failure or some type of standard that probably needs to improve from the institutional standpoint. It's not on you. It's probably like a system failure. You understand what I'm saying? Right? Like, okay, so if a person fell out of the bed, if you have your yellow socks, if you have your yellow wristband, if you have door signs, if you have alerted the nurse, charge nurse, the nursing supervisor, and the patient falls out of the bed, then there's a system problem. I mean, you have done all that you could possibly do. If you call the family, if you try to put the patient close to the nursing station, you have educated the client. So incident reports, as long as you're doing everything that you have to do, then it's a teaching moment. Okay. So 42, medication errors related to systems, procedures, product designs, and practice patterns. So let's break that down. 42, medication errors related to systems, procedures, product designs, and patterns. You see that, guys? Related to system. That's a system error. There's something we need to improve. If there is a medication error, we need to improve maybe the system, maybe the procedure needs to change. So some facilities, you can't even talk to the nurse when they're administering medications anymore. That's a procedure change to prevent or to decrease med error. Product design. Sometimes these medications look exactly like, they have the same box, the same font, the same colors. Or it may be patterns, maybe everyone is having the same issue. So that is one of the reasons why you do incident report. The risk manager told me last week that she gets 335 incident reports a month. And she even said, she's a lot of it is system. It has something to do with the system, so the policies that are in place. Okay, so just remember that. Remember, medication errors related to system, procedures, design, and practice patterns. So 43, report all errors to assist the facility's risk managers to learn how errors occur and what changes to make to avoid similar errors in the future. So we want to avoid the same errors from occurring over and over. So we are making, what changes to make to avoid similar errors in the future. So incident reports or unusual occurrences or variance. Incident reports are an important part of a facility's quality improvement plan. You see that? Quality improvement plan is not punitive. Okay, quality improvement plan. An incident is the occurrence of an accident or an unusual event. An incident is an occurrence of an accident or an unusual event. Examples of incidents are medication errors, falls, omissions of prescriptions, and needle sticks. So examples of incidents are medication errors, falls, omissions of prescription, and needle sticks. Document facts without judgment. Document the facts. And 48, do not refer to the incident report in the client's medical record. Do not refer to the incident report in the client's medical record. So what do I mean by that? I can put patient found, supine position, in room, holding right hip, physician was notified, family member was notified, orders for CAT scan and I don't know, Q4 neuro checks. But I put that in the patient's chart. But did you hear me say, please refer to incident report? No. No, ma'am. I did not say anything about incident report. I told the facts. I did not say, please refer to incident report. So patient was prescribed sodium chloride, patient received potassium, no adverse events noted, physician notified, family notified, nursing supervisor notified, reassess patient at Q 30 minutes, no adverse effects. And what did I do? I notified the oncoming nurse of the occurrence, but not once did I put refer to incident report. All right, so 49. Incident report contribute to changes that help improve healthcare quality. So we're not perfect, guys. So this is for quality improvement. So do your incident reports. All right, because they will help with the system changes. It may be the system may need to be changed. All right, so impaired workers, this is huge, especially when it comes to like this word they use, like confrontation, like you want to confront the impaired worker. Just don't think of it when you encounter this impaired worker, just think of a very sick, drug dependent person. Okay, so this isn't someone that you want to fight with. This is your coworkers. You don't want the coworker, the impaired coworker, providing unsafe care, but at the same time, you're not trying to get into a fight with the impaired coworker. So be very careful about how these questions are worded when you're approaching this situation. So impaired coworkers is a safety issue. As you guys know, as nurses, we have access to all of the opioids, everything. So you may encounter an impaired coworker. So how do you deal with it? So 50, impaired healthcare providers pose a significant risk to client safety. So 50 is risk. They impose a significant risk to client safety. 51, a nurse who suspects a coworker of any behavior that jeopardizes client care or could indicate a substance use disorder has a duty to report the coworker to the appropriate manager. So it is your duty to notify the charge nurse. Listen, in room 3, the nurse seems impaired. I'm letting you know, can you do something now? Let you know the appropriate manager. 52, many facility policies provide access to treatment programs that facilitate entry into a treatment program. It's treatment, guys. So 52 is, yeah, just put treatment. So many facility policies provide access to treatment programs. All right, they will help the nurse. So when you're thinking about this impaired coworker, think of a person who needs help. 53, each state has laws and regulations that govern the disposition of nurses who have substance use disorders. Some states will allow the nurse to continue to work, but not at a facility where they have to dispense opioids. So each state has laws and regulations that govern the disposition of nurses who have substance use disorders. 54, criminal charges could apply. All right, criminal charges could apply. All right, so NCSBN wants you guys to know about the safe use of equipment. So you guys understand about a safe use of equipment. You'll get that. This is threaded throughout all of your textbooks. It's in your fundies book, your pharmacology book. When it comes to the PCA pump, they talk about frayed wires and broken electrical equipment. And so that's all for that. Not too much on this. And mainly, guys, if you see something that is not working, report it right away. Don't use it. All right. So this is your frayed wires, your electrical pumps, and your PCA pumps. You guys know, for the safety of the patient, the family members should not press the button on a patient control analgesic. That's why it's called patient control. So if the patient is unable to push the button, then maybe they need to reevaluate and give the patient a different type of medication. All right, so brainstorm here. Think about electrical, think about safety equipment. And you're not, when it comes to those Hoyer lifts, guys, if you do not have the proper teaching, you don't use them. Any equipment that you honestly cannot use, don't use it, especially with the patient, because it puts the patient at risk. All right, security plans. We discussed security plans, so refer to safety and infection control part 3. We went over security plans at length yesterday, so and you can go to the YouTube. The lecture is on YouTube. All right, triage, which is huge when it comes to security, evacuation. So apply principles of triage and evacuation procedures and protocols. So I really want to talk about this again. Triage is huge for nurses. What I put a picture here. So this is the ED. This is the emergency department. And this is like a mass casualty event. So mass casualty event, and then the emergency department at an actual hospital. So there is no way you triage differently in the ED than a mass casualty event. So these patients, this is a red tag. You see this red blanket? That's a red tag. In the ED, we don't go to the emergency department and go in the waiting room and start tagging patients, right? So it's 2 different ways to triage, and we have to know both. So 55, principles of triage are followed in healthcare facilities involved in a mass casualty event. This is this picture here. So mass casualty event. They differ from the principles of triage that are typically followed during provisions of day-to-day service this picture here, day-to-day service in an emergency or urgent care setting. So emergency or urgent care is very different. This is the emergency room. This is the urgent care. And this is mass casualty event. Two different ways, two different principles. So 57, during the mass casualty events, casualties are separated in relation to their potential for survival, and treatment is allocated accordingly. So you know what allocated accordingly means? That I cannot use resources on a patient who is not going to survive. And that rules applies for this setting, I am not going to use resources on patients who are not going to survive in a mass casualty event. All right, so 58, categories of triage during mass casualty event. So you have your emergent, which is immediate category, and that's your class 1. Class 1, and you can go ahead and put, this is your red tag, right? Red tag. Highest priority is given to clients who have a life-threatening injury, but also have a high possibility of survival once they are stabilized. So this patient has a life-threatening injury, but they also have a high possibility of survival. So that's our red tag patient. So go ahead and take a look here. Red tag. So life-threatening, but also have a high possibility of survival. And then you have your urgent or delayed category, which is your class 2. That's your class 2, right? Class 2. That is your yellow tag. Yellow. That's really yellow. So second highest priority is given to clients who have major injuries, but they are not yet life-threatening. Major injuries, but not yet life-threatening. 62, non-urgent or minimal category. So that's your class 3. That's your green. That's your class 3. That's your green. That's your green tag. The next highest priority is given to clients who have a minor injury, who have minor injuries that are not life-threatening and do not need immediate attention. So the next highest priority is given to clients who have minor injuries that are not life-threatening. Minor injuries. Minor. That's a green tag. And then 64, expected category. So this is your class 4, right? Class 4. The lowest priority is given to clients who are not expected to live and are allowed to die naturally. So the lowest. And this is our black tag. Black tag. So 66, comfort measures can be provided, but restorative care is not. So comfort measures can be provided, but restorative care is not. So let's talk about these 3 little triangles here. All right. So I made a little note and I want you guys to put it in red. In regions where dedicated burn centers are not available or have been destroyed, the survival rate for greater than or equal to 50% total body surface area burns is low. So if you do the rule of nines and you have determined that this patient's total body surface area burns is greater than or equal to 50%, then the survival rate for that patient is very low. So that patient can be considered a black tag. Now, guys, I don't want to give you any type of false reassurance or tell you, okay, it is what it is. You guys know how these NCLEX questions are, but I want you to keep this in mind when you get this burn client. If you do get a question on burns, I want you to kind of take a deep breath and really think about, is this patient going to survive? How am I going to triage this patient? Because burns can get very, very tricky. All right, so this is going to be a doozy for you. So I want you guys to really be secure in your rule of nines and triaging a client who has greater than 50% burns. Think about airway, think about breathing, think about circulation, think about the total body surface area for a burn client. So A, B, C, and then total body surface area for your burn clients. All right, so you're gonna put 66, this guy, this little note, these little triangles, I want you to put them in red, and I want you to really think about, okay, what about 40% total body surface area, 50% total body surface area, 60%? Is this person going to survive? So if you have to look at any videos, whatever you have to do, it would be worth your time to really understand total body surface area and survival potential. Okay. I want to also talk to you guys about agonal breathing. Agonal breathing is when someone who is not getting enough oxygen is gasping for air. It is usually due to cardiac arrest or a stroke, cardiac arrest or stroke. It is not true breathing. It is a natural reflex that happens when your brain is not getting the oxygen it needs for survival. So you'll have agonal breathing. It's not truly breathing. So if you get this term agonal breathing, just go ahead and put not true breathing. Is this person going to survive? What is the survival potential for a patient who is experiencing agonal breathing? Are you going to use your resources on this patient? So agonal breathing is going to be another doozy for you guys. They're going to give it to you in a scenario, and that patient is going to have a lot going on. But I want you to remember, agonal breathing is not true breathing. They're going to put a lot of distractors around this. All right. So this is another little worksheet, a little something that you guys, because I want you to really dig in and understand when it comes to classifying, triaging in an emergency or mass casualty situation. So forget the orange. Okay, but this was the only free image I could find. So, all right. So red, yellow, green, and then black. Okay, so red, yellow, green, black. So think about the respirations for a person who you would triage as red tag. Think about the respiration for someone who you would put a yellow tag or deem yellow tag, green tag, and then black tag. So as nurses, guys, one thing that for the board of nursing, you're not going to get away with not knowing your head-to-toe assessment. All right. That's why when I was a DON, I stressed the head-to-toe assessment. You're not going to become a nurse if you don't know how to do a head-to-toe assessment. And I mean cranial nerves. I mean everything. You have to do it. It's just a rites of passage. And you're not going to become a nurse if you don't understand respirations, if you don't understand the vital signs. As a nurse, we only have a vital sign. We have a blood pressure monitor, O2 sat, we have a thermometer, and we have our assessment. So How are you going to become a nurse if you don't understand vitals and the assessment? That's our job. So what you have to do this week is I want you to really brainstorm. No one has to see it. And if you want to call me and talk about it, we can talk about it. I want you to think about if someone is deemed red tag, what can you anticipate the respirations or as being? Or I want you to do the same thing for blood pressure, heart rate, and I want you to think about the injuries. What type of injuries? Now this I want you to put in red. What injuries would constitute a red tag or a yellow tag, green tag, or black tag? So you have to really dig in. You can't gloss over this one. This one you got to be very, very specific, right? So this week you're going to answer these questions. You're going to do this worksheet this week. So you're going to tell me the respirations for red tag, yellow tag, green tag, black tag. What's the blood pressure for red tag, yellow tag, green tag, black tag? Heart rate and injuries. Okay. So standard precautions, transmission-based precautions, and surgical asepsis. So this is what the NCSBN wants us to know. And the main thing, guys, I would do for surgical asepsis is I would make a little list of everything that is, every skill that requires surgical asepsis. Standard precaution transmission base is pretty standard, but when it comes to the surgical asepsis and the skills, that's normally the issue. So put this in red. You got to make a little list of when do I have to use surgical gloves, sterile gloves, as opposed to just using the gloves that are not sterile, non-sterile gloves. All right, so the NCSBN wants you to assess client care area for sources of infection. They want you to be able to look at the care area and determine, oh, this is not clean. This area, I need to clean this area. Understand communicable diseases and the modes of organism transmission. So you have to know about your airborne, your droplet, your contact. And you also have to know, can you cohort clients? So put cohort for B. Can I cohort? Can I put that client in a room with someone else? If this patient is airborne, can I put that client in the room with another airborne client? Can I cohort? Can I put two people in the same room? So for B, put cohort. C is apply principles of infection prevention. So hand hygiene. When do I use aseptic technique as opposed to sterile technique? Isolation, universal standard enhanced barrier precautions. Follow correct policy and procedures when reporting a client with communicable diseases. Educate client and staff regarding infection prevention measures. Use appropriate precautions for immunocompromised clients. That's your isolation. Is not a transmission base, but it is an isolation precaution. So I want you to put that for F. Use appropriate technique to set up a sterile field and maintain asepsis. Evaluate infection control precautions implemented by staff members. And evaluate whether aseptic technique is performed correctly. All right, guys, just take a little 10-minute break and then we'll come back and knock this out. 10-minute break, guys, okay? Take a 10-minute break. All right, guys, let me know when you're ready. All right, let's go. So let's talk about the isolation guidelines. Okay, isolation guidelines. Isolation guidelines are a group of actions that include hand hygiene and the use of barrier precaution, which intend to reduce the transmission of infectious organisms. So they want to reduce the transmission, all right, of infectious organism. 68. The precautions apply to every client. So every client, we use standard precaution for every client, regardless of the diagnosis, regardless of the implementation of them must occur whenever there's an anticipation of coming into contact with the infectious material. So we use this precaution for every client. It doesn't matter. Standard precaution is for every client. 69, change personal protective equipment after contact with each client and between procedures. With each client and between procedures with the same client if in contact with large amounts of blood and body fluids. So I'll read that again. Change personal protective equipment after contact with each client and between procedures with the same client if in contact with large amounts of blood and body fluids. So it's saying if I do a wound dressing, I don't want to do the pulse with the same dirty gloves. So if I have dirty gloves, even if it's with the same client, I need to change my gloves. I don't want to touch someone's pulse or wrist if I've done a wound of the foot. So 70, clients in isolation are at higher risk for depression and isolation. So that's something that we have to make sure, it's depression and loneliness. So 70, clients in isolation are at a high risk for depression and loneliness. Okay. Assist the clients and their family to understand the reason for isolation and provide sensory simulation. So if we're going to isolate this client, one of the main things that we have to focus on is isolation, depression, and decreased stimuli. So it's not only like it's not only Maslow's hierarchy of needs, like the basic needs. We also have to meet the patient's psychosocial needs. So that's, companionship. We have to take that into account. So it's not only just the basic needs that we're worried about now. We're also worried about the psychosocial needs. All right, so that's huge when it comes to isolation. You got to keep that in mind. The patient may be depressed and may feel lonely. All right, so standard precaution, let's do tier 1. Tier 1. This tier of standard precaution applies to all body fluids except sweat, non-intact skin, and mucous membranes. So let me read that again. This tier of standard precaution applies to all body fluids, non-intact skin, and mucous membrane. So if you have to touch someone's non-intact skin, if you have to go into someone's mouth, you need to wear gloves. That's tier 1. Wear gloves. Gloves. Standard precaution, tier 1. But they're saying sweat is no big deal. Now that's a theoretical world. That's our theoretical world. 73, a nurse should implement standard precaution for all clients. 74, hand hygiene using an alcohol-based waterless product is recommended after contact with the client when the hands are not visibly soiled or contaminated with blood or body fluids, and after removal of gloves. So if the hands are not visibly soiled or contaminated with blood or body fluids, and after the removal of gloves, they want you to use your alcohol base. You know, so if your hands are not, if they don't have blood, if they're not visibly soiled, they're saying that, hey, once you take those gloves off, just use alcohol-based waterless product. 75, alcohol-based waterless antiseptic is preferred unless the hands are visibly dirty, because the alcohol-based product is more effective in removing microorganisms. So you see, they say they're even preferring, because it has an alcohol. They want you to use it. 76, wash hands with soap and water if contamination with spores is suspected. 77, hand hygiene using non-antimicrobial soap or antimicrobial soap and water is recommended when visibly soiled or contaminated with blood or bodily fluids. So visibly soiled. You guys know you have to use soap and water. 78, use soap and water for C. diff. Alcohol is not going to work. They want you to use soap and water for C. diff. 79, remove gloves and complete hand hygiene between each client. So if you go to bed A, after bed A, remove your gloves. Go to bed B, after bed B, remove your gloves. You can't use your same gloves for A and B. 80, mask, eye protection, and face shields are required when care might cause splashing or spraying. Splashing or spraying. Clean gloves are worn when touching anything that has the potential to contaminate the hands of the nurse. So if your hands are at risk for contamination, you need to wear gloves. 82. This includes body secretions, excretions, blood and body fluids, non-intact skin, mucous membranes, and contaminated items. So if you have a patient and there's body secretions, there's excretions, there's blood, body fluids, there's non-intact skin, if you're in contact with the mucous membrane, if you're in contact with a contaminated item, you need to wear gloves. Hand hygiene is required after removal of the gown. So once you remove the gown, wash your hands. '84, use a sturdy moisture resistant bag for soiled items and tie the bag securely in a knot at the top. Use a sturdy, moisture resistant bag when the item is soiled. 85, properly clean all equipment for client care and dispose of one-time use items according to facility policy. '86, bag and handle contaminated laundry to prevent leaking or contamination of clothing or skin. 87, enable safety devices on all equipment and supplies after use. Dispose of all sharps in a puncture-resistant container. So enable safety devices. 88, a client does not need a private room unless they are unable to maintain appropriate hygienic practices. So now the big guns, transmission base, what we've all been waiting for, airborne precaution. So airborne precaution, use airborne precautions to protect against droplet infections smaller than 5 mics. So 5 micrograms. So that's the issue. If the droplet is less than 5 micrograms, then it is considered airborne. 90, measles. 91, varicella is smaller than 5. And pulmonary or laryngeal tuberculosis is smaller than 5. So MTV, measles, TB, varicella. So you have your measles, you have your TB, and your varicella. That's like your shingles or chicken pox. There's your measles. This one must be chicken pox. So chicken pox is varicella. And varicella is also shingles. Chicken pox, varicella. Shingles, varicella. So I sent you guys some CDC pamphlets. Make sure you take a look at those, especially when it comes to Shigella. Now let's go to droplet precaution. Droplet precautions protect against droplets larger than 5 mics. So larger than 5 micrograms. And they travel 3 to 6 feet from the client. So some examples is streptococcal pharyngitis or pneumonia. Haemophilus influenza type B, scarlet fever, rubella, pertussis. Pertussis, that's the whooping cough. I sent you guys a flyer. Mumps, mycoplasma pneumonia, meningococcal pneumonia, and sepsis, and pneumonic plague. So I put little circles here, 9 circles, so you can write them in over and over and over again. So there's 9 of them that qualify for droplet precaution. So you're gonna have to go here and brainstorm and write them in, because that's how we learn. All right, you gotta brainstorm. So use your brainstorm techniques here. So a private room or a room with other clients who have the same infectious disorder. So that means I can cohort. So I can cohort for a droplet, But notice I didn't mention that for airborne. So no cohorting for airborne. So 100, a private room or a room with other. Ensure that clients have their own equipment. Mask for providers and visitors. And 103, clients who have a droplet infection should wear a mask while outside the room. They need to wear a surgical mask. Surgical mask. Make sure you write that down. Surgical mask. And do your worksheet, do your brainstorm worksheet so you'll really know it when it's time for the exam. So contact precautions. Contact precautions protect visitors and caregivers when they are within 3 feet. 3 feet. So that's why it's contact. This is 3 to 6 droplet. This is 3 feet. So contact, you have to really be on this person to get what they have. So what is that? RSV. If you guys click the link, there's a RS. I'll send you the Word document. I got to send you the links. So there's a link. You have to know that RSV is contact and droplet, right? Contact and droplet. Put this in red. Shigella, that's NCLEX. You need to know everything about Shigella. That's an NCLEX question. Shigella. 107 is enteric diseases. That's contact like your C. diff. Wound infections, like especially MRSA. Herpes simplex, I'm going to send you guys the link. Impetigo is, I'm going to send you the link. Scabies, I'm going to send you the link. MRSA, I'm going to send you the link. And the reason why I'm sending you the link is because as my first year on the floor, I experienced, or I had to care for patients with every one of these disorders. Not Shigella, I'm not going to tell that. Shigella threw me, but you need to know it. But the rest of these guys, absolutely. So they're heavy hitters. So I'm going to send you guys the link. This is the link, but you're not going to be able to get it because it's PDF. All right, contact precautions. Contact precaution, a private room or a room with other clients. So put cohort. All right. So you can put cohort for contact precautions. All right, 114. Gloves and gown are worn by caregivers and visitors. So gloves and gowns. $115, disposable or infectious dressing material into a single non-porous bag without touching the outside. So you want to make sure it's in a bag that doesn't leak. $116, protective environment is an intervention. So now we're on protective environment, and I want you guys to put this in red. So a protective environment is an intervention. It's not a type of precautions, and it is to protect clients who are immunocompromised. So this is even for patients who have stem cell transplants. So I want to really put emphasis on this one right here, because this is a question on the board. So this one is going to be very tricky for you guys, okay? Because the problem here is cohorting. Can you cohort a client who with a protective environment, with another client who has to have a protective environment? And the answer is yes. So if you have a patient who has like a surgical wound, who maybe had their appendix removed, or just a clean, non-infectious surgical wound, then yes, you can cohort. So the answer is yes, you can cohort. You can put another client in the room with someone who's on in a protective environment. Okay. So a protective environment requires 118. It requires a private room. It requires positive airflow with 12 exchanges per hour. It requires HEPA filtration for incoming air, and mask for client when the client is out of the room. So a mask when the client is out of the room. So this patient needs like a surgical mask when outside of the room. All right, so restraints, and we are almost done. Restraints. All right, so the NCSBN, the NCLEX, the NCSBN, they want you guys to be very aware of restraints. It's gonna be huge. You can get your drag and drop. You can get your select all that apply from here. Just the rules and regulations that come along with restraints. So nurses must know and follow. They have to follow federal, they have to follow state, and they have to follow facility policy. So federal, state, and facility policies. So there's a federal guidelines, there's state guidelines, and there's the facility has guidelines. Some clients require seclusion rooms or restraints. So some will require seclusion rooms. 124. In general, use seclusion or restraints for the shortest duration necessary, and only if less restrictive measures are not sufficient. So in general, use seclusion or restraints for the shortest duration, and only if the least restrictive measures are not sufficient. They are for the physical protection of Who are we protecting? Physical protection of the client and or protection of other clients or staff. So we're trying to protect the client, we're trying to protect other patients, and we're trying to protect the staff. That is why we use physical restraint. Clients can voluntarily request seclusion if the environment is disturbing or seems too stimulating. And restraints can either be physical restraints, that's like a vest or a belt or mitts, or it can be chemical. So we can use the restraint, but we have to use the least restrictive first. Now, restraints can cause complications. Restraints can cause complications, including pneumonia, it can cause incontinence and pressure ulcers. So pneumonia, incontinence, and pressure ulcers. So they can lead to complications. Now, it is inappropriate to use restraints for the convenience of the staff, punishment, clients who are extremely physically or mentally unstable. So if they're extremely physically unstable, meaning that their vital signs they're septic, or they are mentally unstable, then you cannot put them in a restraint safely. You got to figure something out, and it's not restraint. 32, clients who cannot tolerate the decreased stimulation of a seclusion room should not be in a seclusion room. If they can't tolerate it, then you can't put them in a seclusion room. We got to try something else. 134, restraints should never interfere with treatment. They should never restrict movement. They should restrict movement as little as is necessary, because you're worried. And I want you guys to put for 134, aspiration and pneumonia. 135, restraints should fit properly, and they should be as discreet as possible. 136, they should be easy to remove. 137, when all other less restrictive means have failed to prevent a client from harming themselves or other orientation to the environment or others' orientation to the environment. So I have oriented this client. I have done diversionary techniques. I have tried musical therapy. I've called the family member to tell the family member to bring the patient in. I've sat the patient at the nurse's station. Now I have to resort to restraints. So restraints should be have a supervision. Supervision is required of a family member or a sitter. Diversional activities have not worked. Electronic devices. So let's say, for instance, in some facilities, they have this screen, like this iPad, and they'll give this patient just to try to distract the patient. If that hasn't worked, if supervision of the family member or a sitter hasn't worked, if diversional activities haven't worked, if all electronic devices haven't worked, The following must occur before using seclusion or restraint. So you have to go, you have to go to the full out extent. Supervision, you have to call the family member. And sometimes you still have to make sure that the family member can handle the situation. Diversionary activities, electronic devices. I have to do all of these things before putting the patient in restraints or seclusion. So 142, the provider must prescribe seclusion or restraints in writing after face-to-face assessment. 143, in an emergency situation, when there is immediate risk to the client or others, nurses can place restraints on a client. So you can put restraints if in an emergency situation without the order, but the nurse must obtain a prescription from the provider as soon as possible according to the facility's policy, usually within 1 hour. The prescription must include the reason for the restraints, the location of the restraints, how long to use the restraints, and the type of behavior that warrants the restraints. So again, 145, the prescription must include the reason for the restraints, the type of restraints, the location of the restraints, how long to use the restraints, and the type of behavior that warrants the restraints. 146, the prescription allows only 4 hours of restraints for an adult, 2 hours for clients ages 9 to 17, 1 hour for clients younger than 9 years old. Okay, of 24 consecutive hours. So the prescription can allow for 4 hours for an adult, 2 hours for clients 9 to 17, and 1 hour for clients younger than 9. 150, providers cannot write PRN prescription. No way, no PRN, no as needed prescriptions for restraints. 151, explain the need for restraints to the client and family, emphasizing that restraints keep the client safe and they are temporary. And guess what? Ask the client or guardian to sign a consent form. Review the manufacturer's instructions for correct application. And 154 is very important because this is us. Assess skin integrity and provide skincare according to the facility's protocol, usually every 2 hours. So every 2 hours, you need to remove that restraint. 2 hours means remove and assess. You can put it back on, but you need to remove it. Offer food and fluids. Provide a means for hygiene and elimination. Monitor the vital signs. Offer range of motion exercises. 159, pad the bony prominences. 160, secure restraints to a movable part of the bed frame. 161, if restraints with a buckle strap are not available, use a quick release knot. Quick release knot. 162, make sure the restraints are loose enough for a range of motion and that there is enough room to fit 2 fingers between the restraint and the client. 163, remove or replace restraints frequently to ensure good circulation to the area and allow for full range of motion to the limbs. 164, conduct an ongoing evaluation of the client. 165, regularly determine the need to continue using the restraints. 166, never leave the client alone without restraints. 167, check facility policy regarding types of restraints. 168, many facilities no longer use vest restraints due to the risk for strangulation. So they're not playing around with these vest restraints anymore. $169, document precipitating events and behavior of the client prior to seclusion of restraints. 170, alternative actions to avoid seclusion or restraints. You have to document this. Time of restraints and location of the restraint. 172, type of restraints and location. 173, the client's behavior while in restraints. 174, type and frequency of care. 175, range of motion. Neurological checks. Removal and skin checks. 176, condition, underlying condition of the body part in restraints. 177, the client's response at removal of the restraints and medication administration. So that's a tall order. So down here under documents, I want you guys to put your circles and I want you to write this documentation, what you need over and over and over. Because this is a good select all that apply. This is a very good select all that apply. This is a very good drag and drop. And it's word for word, guys. They're not going to be able to change the documentation. So I want you guys to do your circles and fill it in. All right, guys, that is it. I will see you. I'll let you guys know next week what time, because it won't be Friday and Saturday because they have me on the schedule for Friday night, Saturday night. So I'll let you know my schedule tomorrow afternoon. I'll send you guys an email with health promotion and maintenance package. So I'll let you guys know either way. The recording will be on YouTube. All right, guys, see you later.